So the really good news for our patients with CLL is we've got access to new agents that are very, very effective with low side effect profiles that are particularly effective in those groups of patients in whom until very recently we had no very good choices at all. Now, there is of course the concept with all of these agents, so that's with Ibrutinib, idealisib and rituximab and with Venetoclax, that all of these agents require you to go on a treatment and pretty much stay on it all your life. It's a little bit like moving from, instead of treating a cancer, to almost like having hypertension. You're going on a drug and controlling something and staying on it very long term. Now, there are two issues that you want to consider when being on these types of agents. The one is, what's the right agent for you based upon other treatments that you may have or other comorbidities? So, for instance, people with bleeding risks or people on anticoagulants. There are some potential risks with Ibrutinib. Patients who've got any type of autoimmune disease, there would be concerns with idealisib. So there are concerns that you have to think about. But in general terms, what we find is these agents are extremely well tolerated, pretty minor side effects, and of course, when it comes to Venetoclax, the only real problem we're seeing is this issue of what we call tumor lysis. Venetoclax is so active, it kills off the CLL cells so quickly that you have to be careful about when you start it, that it's done very carefully with a ramp-up dose. But most clinicians don't consider that to be a risk of the drug. They consider it a good thing, just something that has to be monitored very carefully. What this means for our patients with CLL is that whereas we used to be talking about stem cell transplantation when you had some poor risk features, these new drugs that work so well in that setting mean that transplants being pushed back further and further, and the data very clearly shows that we're doing very many fewer transplants for CLL than we were before. So when I'm meeting with patients and talking to them about, transplant might be on the horizon, and we're talking about, either we can continue the drug that you're on right now, you're tolerating it well, but we've got to be aware that at some point in the future, the disease is going to come back. We don't want to be trying to wait until we've missed the window of opportunity when a transplant can be undertaken very successfully. So it's then about identifying, is there a natural time to be thinking about moving for a transplant? What I do with my patients is sit down, and even if they're responding well to those therapies, if they've got high-risk features, I'll be having a conversation about, let's at least look to see whether you've got a donor. Let's have something set up. Let's not be rushing to try to find something if you don't respond well to that therapy. Let's try to have everything set up so that when or if the time comes that a transplant becomes an option, we're ready to go and can move quickly before we're allowing the disease too much time to explode.